day of, the day before, so I'm praying. Actually, there's a lot missing, so they're probably going to view it. It is my absolute pleasure to introduce Dr. Terry Lennie, who's going to come and share with us today a little background on Dr. Lennie. He got his BSN at Marquette University, and then both his MS and PhD at the University of Wisconsin-Milwaukee. Madison, I'm sorry, did I say Milwaukee? Madison, excuse me, Lieutenant. And then, I don't know how they let him go to the University of Michigan from Madison, but he spent 2 years on a postdoctoral fellowship there. Someone made the comment, you have a lot of initials behind your PhD, RN, FAHN, which I take as a fellow of the American Heart Association, and I didn't know what FAAN.
It's a fellow, it's the American Academy of Nursing.
Fantastic. He's an incredible researcher. He also, is an editor. He is the director of graduate studies, the PhD in nursing here at UK. He's on Liz's dissertation committee, so on and so forth. It's my pleasure to introduce Dr. Terry Lennie.
Thank Jody for giving me the privilege to come here and speak with you. So I'm delighted to be here, and I also want to thank Jody because she also has been a great colleague of ours over there, and she sits on several of our students' dissertation committees and has advised a number of our students, sharing her wisdom with us as well. So we're lucky to have her as a colleague as well. I want to note that I have the privilege of working with a group of investigators in the College of Nursing that are all focused on promoting cardiovascular health, which is one of the big problems in Kentucky. I particularly, right now I'm focusing on heart failure, and to be truthful, exercise is not my area of really research, but there's a lot of commonalities here as well. Mine's on nutrition, so we'll a bit later just try to integrate how those two approaches, or at least getting people to engage in those approaches can be similar and matched as well. So what I like to do is just give you an overview of heart failure, just a little bit of background so we all have it coming from the same frame of reference. I want to talk a little bit about this idea of challenging assumptions, and this is what I'm going to show you in heart failure has also happened in a lot of other chronic diseases where our perspectives have to change in the way we approach helping people with chronic diseases as well. And then I'll talk about exercise and heart failure, some of the barriers that are there, some of what we know are the benefits, and then some of the evidence to support whether or not exercise is beneficial in heart failure, or I should say the limited evidence available as well. And then talk about someone that I want to share a little bit of mine, because I'm going to shamelessly promote my research as well, and then talk about how these approaches can be integrated or share similar approaches. If we could, so heart failure, how many are you familiar with heart failure? Somewhat? So it's the end stage of all cardiovascular diseases. So if you live long enough, you have cardiovascular disease, and likely if you live long enough, and people are now because we can save them from acute myocardial infarctions, likely you will end up with heart failure. So it's a growing problem, a worldwide epidemic, and it's likely to get much wider as well. Nobody really likes the term heart failure, but we still use it. So someday they'll come up with a better term. But it's really a clinical syndrome, so it's not a disease. People try to talk about it as a disease, but it's a syndrome, and it's a syndrome that's primarily evidenced by symptoms. Now, there's underlying pathophysiology that's there, but it really is driven by symptoms. So it really is the heart, obviously, is just not able to pump sufficient blood to meet the metabolic needs of the body. So it does end up in a lot of fluid overload, so people become edematous, and they also have a lot of other manifestations of poor perfusion over time. It really is clinically characterized by symptoms. You see dyspnea, activity intolerance, a biggie for us here today, heart dysrhythmias, very poor, often very poor quality of life, and very poor prognosis. People with heart failure have one of the worst prognosis. 5-year prognosis is even the only two diseases that have worse prognosis than heart failure are lung cancer is one, and I think ovarian cancer are the only other two. So heart failure has a very poor prognosis. We're getting better at this. They've probably pretty much done as much as they can, probably medically now, with what they know. So a lot of what else has to be done now are lifestyle interventions, non-pharmacological interventions, which are really having quite a powerful effect as well. I just want to talk to you about how we actually classify patients with heart failure. Now, we can measure things like ejection fraction and know that, and kind of mark somewhat of the severity of heart failure, but there's really not a good match between a person's ejection fraction and actually the symptoms that they experience. So it's really, that's actually not often used. It's used as a marker to help diagnose or determine what type of heart failure people have. But if you're really going to manage people's heart failure, it's managed by their symptoms. So it's really a symptom-driven condition. I think one of the things you're going to notice here as a theme that really has to do with this whole idea of exercise is always, every single one of these is what? Symptoms in relation to activity. So we're going to try and put, so this is always a symptom-driven, and it's always this way if we're going to see whether or not treatments are being effective. It's really based on their responses to their ability or their symptoms that are related to activity. So people that are in class 1 can actually, it's really rare to find people in class 1 because they're pretty much, they become symptomatic, but it's at a fairly high level of physical activity. So it's above the normal, above what normal activity is as well. Some people with mild or class 2 heart failure, they have a slight limitation in physical activity. They're comfortable at rest, but some of the ordinary physical activities result in fatigue or dyspnea. So it's the idea of getting up, before they used to be able to walk up a flight of stairs, and now when they like to walk up a flight of stairs, they get really short of breath. It's really hard for them to do. People at class 3 are really much more physically limited, so they're still okay at rest, so that they sit and they rest. But ordinary activities like just getting up and going to the kitchen or getting up and trying to prepare a meal starts developing symptoms of dyspnea and fatigue as well. So they become fairly moderate. What happens with these people often is they just stop doing things so that so that's how they compensate. Sometimes you'll ask them and they'll say, well, are you short of breath? Oh no, I'm not short of breath at all. That's because all they're doing is sitting around and not doing anything, so that's why they're not short of breath. So they, over time, compensate. People in class 4, severe, are actually symptomatic even at rest. These are the people that often end up having heart transplants or put like an LVAD, a left ventricular assist device in. So those are the ones that are pretty severe. So this is truly end-stage heart failure as well. We mostly work with people in this area because these are the people where we can make modifications, lifestyle modifications in addition to medication to actually help them improve. These people, it's not much that we can do to help them because they're beyond, well, obviously they're beyond help, but they're beyond what we can do mostly. They have to, they need more advanced treatment. So I'm going to talk about some of this whole thing about challenging assumptions and making sure what we were doing is beneficial. A lot of what we used to do in heart failure and other chronic diseases thought to be beneficial. When we start looking at it, it may not actually be. So we start challenging some of these assumptions. And one of these was this whole concept has been developed called reverse epidemiology. So it's the idea that factors that are related to the development of a health condition convey a positive survival value once the person develops it. And usually when we did this with heart failure, and I'm going to show you an example of obesity being one of those, because people who are obese have a high risk of cardiovascular disease, but they also have a high risk of developing heart failure. So we always thought that if somebody was overweight or obese and they developed heart failure, what we would need to do for them is tell them, well, if being overweight is what got you in trouble, then actually losing weight should get you out of trouble or help you. And that was a lot of what we were doing before with these people. But now there's some data that challenges that. And I'm just going to show you a little bit of this as well, because there's a lot of it out there. But when you look at obesity, there's all kinds of health risks there that are related to this. This is an old one, so it's like type 2 diabetes. But a lot of these are there. One of these is heart failure, and I think always are things. And we know that some of these, like if you do, whoa, is that the eject button? Yeah, it was. So you know that if we have people lose weight, they can treat hypertension in people who are obese by having them lose weight. So that is actually one where it seems like it got them in trouble, making them lose weight helps. But there are others, like heart failure, where that may not always be the case. So it was interesting, and I don't actually even know why they did this study in the first place, but I'm going to show you one of the first studies that generated all this, and since then there's been a whole bunch of other studies that have come since then, and it's really the data from now is well over 120,000 patients now, that has shown that patients who are overweight or obese actually have better outcomes and survive longer than patients who are normal weight or underweight. Underweight makes sense, but the normal weight people, that's what we always want to try to do is get these people who are overweight or obese when they had heart failure to start losing weight and become normal weight as well. So this was, I'm going to show you the first study that generated all of this. This was out of UCLA. So it was 1,200 patients, so it wasn't a small sample size. And these were people that were here for a heart transplantation. So these were the people that were close to class 4. really pretty severe class 3 or class 4. So these were the end stage people that are truly end stage heart failure. So these were the sickest of the sick, to so to say. And they were referred for heart transplant. They were divided into body weight categories based on BMI. And then they compared their survival over 2 years. And now when we talk about survival of people that are eligible for heart transplant, if they get a heart transplant or they're moved up for urgent heart transplant, they're considered, when you do an outcome, they're considered to die even though they're still alive, because they would have died if they didn't get the heart. So those also include there. So it'll be people who actually died or people who end up with an urgent heart transplant for survival. Now, if you only know anything about obesity and comorbidities, if you're obese and you have, the more comorbidities you have, the worse outcomes you would be expected to have. That just makes sense, and that's where we all come from. So here are a couple of people. So these are the people that are underweight. Obviously, BMI is less than 20.7. Here we got people that are essentially normal weight. These are overweight, and these are obese people. And you'll notice the stretch there. We have the biggest number of these people are normal weight, actually, in this group. You can see their ejection fractions are pretty low. So we would like something much higher, 50 or higher in there. These are the percentage of people who had diabetes, and it makes sense that more people in the obese group would have diabetes. And also the thing about people who have hypertension, it makes more sense that a greater percentage of the people who are overweight would have diabetes. So we know these people are overweight, and this group has a much higher incidence of comorbidity. So we would expect, for me, clearly from what we thought, this is the group that should have the worst survival. That probably should have the second worst. These ideally should have the best survival, at least from our perspective. So here's their 2-year survivals. As you can see, in 2 years, 51% of those people were still alive. So 49% had either died or had a transplant. This is slightly better, so 55% there, as you can see. Go up here now, you see these are actually better. 60% of these people were still alive. And when you go to the people that at least we perceive which should have the highest risk and have the worst outcomes, 63% of these people. So these people did the best. They survived the longest as well. So this would sort of set this off to say, okay, what we're thinking about here probably isn't as well. These have the highest number of comorbidities and they have obesity. They should have been the ones that died, but they were the ones that are surviving. So people since then have gone on and done a number of other studies, and pretty much every single one of them has shown that overweight and obese patients do better. They live longer, they have longer survival. And so then they went and did body composition, and it's clear that it looks like it's the body fat that's conveying the survival and not the mass. So it kind of challenges conventional wisdom. So other people thought, well, if it's just obesity, what about other things that we think should be treated or be better? So they looked at blood pressure in a large group, and this was a secondary analysis of a digitalis trial. You can see this was 5,700 patients in this group. And you can see their survival. Are you familiar with looking at survival curves? So you see over 2 years, and this is the percent of people who were still alive, survival. This lowest number here is the people who had a systolic blood pressure of less than 100. Not surprising, perhaps, that they were the ones that weren't going to survive. But we know that the people here that are up here where we're starting to classify people as hypertensive, which is this top one, those are the people that have the best survival. So again, I think our tendency would be, particularly in patients with heart failure, if they're hypertensive, let's treat that hypertension, decrease the load on the heart. But those are the people that are actually surviving the longest once they get heart failure. Hypertension can be something that causes heart failure, but now once they have it, it looks like it's more beneficial. Same thing happens with diastolic pressure. Here's diastolics less than 60 are here, and they go on up. These are the people, this top number again, are people with diastolic blood pressures greater than 90. Again, definition of hypertension. Those are the people that are surviving the longest. So it's counterintuitive to what we were thinking. Other people thought, well, let's look at something else, and this is hypertriglyceridemia. Another thing that when we look at that, we think we've got to treat it. Right away, give them drugs, treat it. So they looked at a number of patients. Now this was a smaller group. It was 114 patients. They were all optimized under medication treatment. So they were getting the ideal treatment being followed by some of the top cardiologists in Europe. And they followed them for 3 months. And then they looked at their cholesterol levels over time and then looked to see who survived. Okay, so this is interesting. So we have the cholesterol levels down here. Whoops. Keep pushing the wrong button. This one here is the ones that have cholesterol levels of 100 to 173. So these are almost in our target range where we'd like them to be treated. They're the ones that you can see their survival is not all that great compared to the ones The ones that are doing the best are ones that probably make a lot of clinicians go crazy. These are cholesterol levels of 231 to 350. These are the people that are surviving with massively high cholesterol levels. Again, challenges our conventional wisdom. So I think we have to start thinking about, okay, cholesterol might have been one of those things that contributes to atherosclerosis, maybe contributed to development of heart failure, but once they were there, the people with the high cholesterol were the ones that are surviving. So it kind of challenges our conventional wisdom to saying, we have to start thinking about when people develop chronic illnesses, of not saying, okay, let's think about what to do for now versus what got them in trouble. Maybe we have to think about what to do differently now as well. So I think it challenges the way we start thinking about things as well. Okay, so exercise was one of those other things with heart failure where our wisdom was, you see, it's all symptom driven, and we know that the more active people get, or when they engage in activity, they become more symptomatic. If we're trying to treat symptoms, minimize symptoms, what would be the one thing we would probably tell people to do? Well, you would think we would, but what they were telling people to do is, well, if you become symptomatic, you've got this heart, it's a sick heart, it can't pump all that much, the last thing we're going to do is give it more activity or something to challenge the heart even further. So what we did, and they did this from the time of Egyptians up until the 1980s, when we probably didn't have a lot of medications. So what we did there is the primary thing we did for people with heart failure is put them on bed rest. That was the wisdom, because it made them less symptomatic. If we're trying to treat symptoms and minimize symptoms, and activity causes symptoms, we put them on bed rest. So that happened up until the 1980s, from way back in the time of Egypt. Then they started putting on some, started finding some drugs that might work. They found diuretics to get rid of the fluid. They actually did vasodilators because these people were seriously vasoconstricted. But you'll notice what happened here. Up here, this is all just non-pharmacological. Then they found the drugs, and what happens lots of times is what? Guess what went away? All the non-pharmacological interventions just went away. And they said, well, we can just treat them with drugs. And so they were doing this for a long time, treating them with drugs, and they finally realized now they've optimized them on drugs, and people are still, survival's gotten better, but it's still not all that great. So a lot of us are now coming along and saying, well, now you need to go back up and combine some of those non-pharmacological interventions with the medications and see if we can't further enhance survival as well. So the challenge was, because this was the one that was in there before, what happens now? So the prior wisdom was that bed rest was ideal for these patients. It minimized the symptoms. The heart was considered a starving organ because it just wasn't giving enough blood. So that it would also decrease the acceleration or progression of left ventricular failure if you did challenge the heart and make it work even harder. So this was the prior wisdom. But now somebody said that we understand that inactivity, as you probably are all well aware, right? It actually leads to physical deconditioning that increases symptoms and increases activity and tolerance. So the more they're rested, the less than they can do in the end. So we develop this downward spiral. You're somewhat active, you do this, you stop, you limit your activity to limit your symptoms, and then the less activity you do, you become even more deconditioned, which means then you do even less activity, you become even more deconditioned, and so it became this downward spiral. So what we needed to do in this case is try to reverse that. And it also compares peripheral vasodilation, which is one of those things we want to do with patients with heart failure because they are vasoconstricted. So the current wisdom now is that exercise training increases exercise capacity, it lessens symptoms, it actually improves quality of life, it improves skeletal muscle metabolism, and has effects on peripheral vasodilation comparable to drugs. So these exercise can work as well as drugs in a lot of these cases. So in addition to drugs, it becomes a nice complementary treatment. Now these were all based on studies, as you can see, studies where they ranged from putting patients with heart failure, getting them 40 to 70% of their maximal effort for 20 to 45 minutes per day, 3 to 5 days per week, and these were for trials of 8 to 12 weeks. This is a challenge for people with heart failure who are symptomatic when they become active. So this becomes a challenge for us, but this is it. So these were all done in really controlled trials, bring people in, get them to exercise in these controlled trials. So this was the conventional wisdom doing this. These were small trials, limited number of time, but it looked like this was promising. And And this is like, we're only talking a few years ago for all of this. So based on that, the American Heart Association, American College of Cardiologists, they put out combined guidelines for heart failure. They put this in there as a recommendation. Now, exercise training is beneficial as an adjunctive approach to improve clinical status in ambulatory patients with current or prior symptoms of heart failure and reduced ejection fraction, so the people whose hearts aren't pumping as they should. And it's a fairly decent level of evidence. At least there's some trials there, not large clinical trials, but there's some trials to support this. So this is the recommendation out there now. How well has it been implemented? Well, what happens here is obviously there's a huge barrier. Patients become symptomatic in response to activity. So we're going to go out and tell them to do something that's going to make them actually feel worse. And it's happened. So you tell them to go out and do exercise, and actually they feel worse after doing it. So there's no reward there, actually, because what they've been trying to do for the last several years with heart failure is not do activity to minimize symptoms. Now we're going to say, okay, you go out and do activity. It's going to make you more symptomatic, at least for a while, but you should really do it. And also the majority of them are beta blockers, which blocks the sympathetic nervous response. So, and again, in addition to activity, they're not going to be able to, they don't actually be able to mount, increase heart rate or force a contraction in response to activity, which is normally what we would do in exercise. So we have these couple of barriers here to try to tell people to do something that obviously inherently they don't want to do because it's going to make them more symptomatic, and we've given them drugs which actually blocks their ability to actually respond to this activity as we thought. So this really was a challenge. It seems somewhat counterintuitive to tell these people to do that, and they feel that way as well. So just a few years ago, a group of investigators just got some money from the National Heart, Lung, and Blood Institute to mount this really large clinical trial to see whether or not exercise would improve outcomes in patients with heart failure. It was called the ACTION-HF study. So they had two treatment groups. One was a usual care group, so these were people that were on their medications, optimized on that. They had some patient education on how to take care of their heart failure, and they got phone calls just to help them maintain their self-care as well. People in the exercise training group were optimized on their medication, had the same phone calls as well. They had supervised training. They had a whole period of supervised training, like you do, bring them in almost like a cardiac rehabilitation, bring them in. And that was the point. If you can get these people in there and get them exercising and get them past that really hypersymptomatic phase when they initially start exercise, when you start seeing the benefits of exercise when they actually become less symptomatic and more tolerant to the activity, if you can get them past that threshold, then maybe they'll engage in it more. So we got to get them past that early hypersymptomatic phase. And then they went into a home training session. And they really went all out on these people. They brought them in like exercise equipment into the home, had it set up for them, so they had it. So this was a huge, very expensive study to do this. So they did what they thought they could absolutely do to facilitate the ability of these patients to exercise. They did something called an intention to treat analysis. Do you know what that is? It's when you put people in trials, like a drug trial or some kind of clinical trial, and you put them in there. So you have your experimental group and you have your comparison or usual care group or control group, and they stay in those groups, and you include those people in the analysis all the way through, regardless of actually. If you put them in and put them on medications, and you say you're in that group and the person never takes their medication, they're still in that group with the same people as do. So what happens here is you get a whole bunch of people in your experimental group that may not have actually done your intervention, but you're comparing them, their outcomes are in there with everybody else. And then you have your usual compare group. And I think they do these because they think if you're doing a drug trial and you give a medication to some people are going to follow it very closely, some people aren't going to do it very well at all. But overall, if there's enough, if you've got a big enough sample, even if you pull out all that noise in the system of those that are adherent and not adherent, if you get better outcomes, then you really know that drug works, and it probably would work even in the real world where people aren't going to do it the way they're supposed to do it. So they did this, but when you do this with a trial where you likely know that you're going to have a really high level of non-adherence, you really set yourself up for failure, because you're going to have a lot of people here where you're just going to see, did my intervention work? And then if half or more of your people actually didn't do your intervention, it kind of defeats your purpose of really finding out whether or not it actually works. But they did an intention to treat. And then they did these compares time to event, and I'll show you what the different events were as well. and then they did the relative risks to see whether or not the risks were higher or lower, depending on the risks of survival were higher or lower, depending on whether you did the exercise or not. Okay, so one thing that was nice in here when we look at this adverse events between the two groups, here's the usual care. You see there was 1,100 people in here, and about 1,100 in each group. So these were pretty big trials to do this, and there were multi-sites. But you can see at least one cardiovascular event, which is either worsening of heart failure symptoms, angina, serious arrhythmia, stroke, or TIA. But you can see, even if the exercise training group, this way the incidence was pretty similar. The same thing for if people had an implanted cardiovascular device, whether or not it fired, the rate was the same. Whether or not they were hospitalized after a bout of physical activity, so that we assume is due to their just engaging in physical activity. Hip fractures of pelvis from being active, and then also deaths identified as occurring within 3 hours of doing a bout of physical activity. You can see that the incidence of those is the same in the exercise group as the usual care group. So obviously the exercise group in this place we're saying was safe. It was safe, so it didn't increase risks. So that was encouraging as well. So then we look at the outcome, and here's the survival curves. Ideally, we'd love to see these separate really nicely and see these big events. So these are now the event rate. So the higher the rate, the worse the outcome, and the lower the rate, the better the outcome. You can see the top button here is the exercise, the usual care group, and this is the exercise group. And you can see that I followed them for 3 years, and there's it is significant. There's a slightly better, lower event rate in those that did the exercise group, but it wasn't very dramatic. So this is for all-cause mortality or all-cause hospitalization. So the people, whether they died or whether they had an event where they were hospitalized over those 3 years. So it's not a big difference here. Then they did mortality or hospitalization just related to cardiovascular. Yes?
Just curious, did they measure compliance then? They're using intention to treat. Did they
Yes,
measure
they are.
compliance?
So that's a good question. Now, I'll get to that in a minute. And you can see this as well. So this is cardiovascular related, which you think if you're doing exercise in patients with heart failure, this would be the one where you might see the biggest difference, or like to. At least you can see, again, not a huge difference. It becomes it's not, if you just look at just the event rate between those two groups without controlling for any other comorbid conditions, there's no significant difference. But if you adjust it for some of the comorbid conditions that people have, take out some of the other causes that might be related to hospitalization, it becomes significant. So it looks like at least exercise contributed a little bit to lower event rates in that group, but it's not a dramatic difference. And this is just purely all-cause mortality. This was their primary outcome, just all-cause mortality. Did people die or not? And there was no difference in this. So it doesn't make people, this exercise intervention, people didn't live longer if they did the exercise. So, and I think sometimes that's what people, will it make me live longer? If you want me to do this and make me feel lousy for a while I'm doing this, if it's not going to make me live longer, why would I do it? So that was part of the problem. So for them, I think this was a big disappointment because they had this huge trial, spent this money, had a lot of press, and they came up with their major outcome, and there was no difference. So that was it. So what happened here, and this is this question comes up, is they realized they had suboptimal adherence in the exercise training group. And they thought maybe the usual care group might have thought, caught wind that the people were doing exercise and they might have increased their activity. Don't know that that's true, but they thought that might have been there as well. So they thought that might have been that. Obviously, you can't blind subjects to this, or the personnel, because it's one of those things where you're giving the intervention so people know they're getting it or they're not. Although some of the people that were doing the outcomes were blinded, so they didn't know who was in what group. But obviously the people administering the interventions did. So that was it. So then let's look at the training here, so you can see this level of adherence that went on in here. So what you see here, so this early part here was 1 to 3 weeks. So this was the early period when they brought people in and actually did the sessions with them and got them training to get them to do exercise and show them how to do it. So this was the controlled exercise one when the people were there and people were monitoring them to see the number of minutes. Okay, so this was the goal. What you're seeing here, this little red dot is the median number of minutes that people exercised in those groups. You can see the median didn't quite, so even as a group under the supervised one, they didn't quite meet the goal, okay? And this is the number of people then who were above the goal, and this is the number of people who were below the goal. So we had a bunch of people down here that were only doing, the thing was 90 minutes, and they were only doing 40 minutes. And this was during the supervised session when there were people there encouraged them to engage in activity. Then what you see here, the rest of this here, it then is over time, weeks. These are months now. I'm sorry, that was 1 to 3 months of supervised. And these are months over time. So we're out here at 3 years, which is the length of the intervention. Here was the goal. People were supposed to reach and do 120 minutes of exercise per week. And you can see the median amount of exercise by the group per week certainly goes down over time, so it's not very sustained as well. So this is that problem with looking at adherence to this, which is an issue. So we'll just look at this point. You can see now these are the people that either met or exceeded the goal, and you can see it starts out here. We have some people that are very, very ambitious. So we have some people here that really seem to have taken exercise seriously for a while. But again, what happens over time is they obviously lose interest over time as well. This doesn't surprise you, does it?
Did they stratify amongst the most active to see if the outcomes were any better?
They're starting to do some sub-analysis now. Really doing that. And they've looked at other things like quality of life, and actually in people that were exercised and did this, quality of life goes up. So there are a number of sub-analyses out there now. They're looking at it. But this was their primary outcome, and they did an intention to treat, and you can see when you're getting out here, nobody's doing the treatment that you intended, so it becomes sort of confounded as well. So this was the issue. It becomes an issue with this. It becomes an issue if you get people to do something that we know is beneficial, even if we get them to start it. It's always been a question for us when we're doing exercise, how do you sustain it over time? It's a big issue. It's an important intervention. It looks like it's beneficial. It's safe, but people don't want to do it as well. So that's the challenge. It's getting people to engage in a behavior that we know is beneficial for them and to maintain it over a long time. Yes?
Are they following up with the quality of life, or did they collect that?
They have quality of life, and some of those, I should have brought it up. If you're interested in looking at this, because there's 2 talks out there, and I took some of these from the talks, but if you actually just Google Action HF, it should bring up, there's 2 talks from the primary investigators. One is this talk where they talked about the primary outcomes, and they talk about this, and he does at the end talk about this whole issue of people not actually following the intervention, and what the challenge was for that. There's the second talk in there where one of the investigators does a lot of the secondary analysis, where they're looking at some of the other outcomes, quality of life, and some of those other outcomes to show what they look like as well. And I didn't stick that in, but that's out there. So it is beneficial for those that follow it. It looks like it is beneficial. So I have this challenge where I'm doing nutritional interventions in patients to decrease symptoms of heart failure. We just got us funding to do a study now that combines 3 types of interventions. So we know heart failure is a symptom-driven condition. We know now that exercise probably could improve symptoms as well. I am a believer that nutrition can play a big part in this as well. There are 3 primary pathologic mechanisms that underlie symptoms in patients with heart failure. One is the fluid retention that occurs. These people become edematous in the periphery as well as in their lungs. They develop a lot of oxidative stress because of just impaired perfusion in them as well. And they have an old underlying inflammatory process, also probably related to impaired perfusion. So we thought what we could do. The other thing we wanted to do is we wanted to develop an intervention that was doesn't cost a lot of money and could be done at home by patients. Because what happens here is lots of times we develop these big trials for people, and you come in like the heart failure, where they came in people's houses and brought them their treadmills and set them all up for them and did all this training. Well, that's not something that you can do, So it worked for them, but the normal people wanting to intervene can't do that because we can't go out and buy treadmills for everybody and come to your house and teach them how to use it. So we wanted something that actually would be relatively inexpensive that people could do even if they didn't have the resources of the study to help support them deeply. So we wanted something that was inexpensive, that actually might work. Okay, so here's my framework, and I'll just kind of show you where that works. So and again, it's all symptoms, right? So we know that if people eat sodium, it's one of those things that causes fluid retention. So if we can restrict the amount of sodium people eat, it decreases the fluid and actually should help treat symptoms. So too much sodium leads to fluid overload, which leads to edema, fatigue, shortness of air, and hospitalization and quality of life. So we know if we can restrict sodium, that'll be one of those things that happens. We also know with decreased cardiac output that also causes hypoxia, which again stimulates oxygen-free radicals, which actually then those free radicals scavenge nitric oxide, which doesn't allow the blood vessels to vasodilate. So if we can actually limit the amount of nitric oxide that's scavenged by these free radicals, we should actually help be able to increase vasodilation in those patients and decrease this whole thing of increased workload and decreased cardiac output. Those free radicals then go on to cause cell damage, which causes inflammation, which also then causes anorexia and fatigue. And it also causes disease. So we had this idea of thinking if we can target these three things, sodium restriction, if we can give them something that helps, that's an antioxidant, and we can give them something to decrease this inflammation, we should probably be able to decrease symptoms in these patients as well. So that's what we did. We did this. We're doing this study of omega-3 supplementation to decrease inflammation. Tomato juice in V8 has a high amount of lycopene in it, and lycopene is a pretty potent antioxidant. So it works, and we did a pilot study where we know that giving the amount of V8, just like 11 ounces of V8 or 8 ounces of tomato juice a day, raises the antioxidant levels in the blood. It's sufficient enough to be really effective. And we put them on a low sodium diet. Now, how many of you ever tried to limit the sodium in your diet? It's not easy. And it's not all that tasty either, actually. So again, we have the same challenge, getting people to do something that we know is beneficial for them, but they probably don't want to do. And they're probably not going to do it over time as well. So it's the same issue with the exercise, is how do we get people to do something we know is beneficial? So what we had to do is turn to something called motivational interviewing. Have you all heard of that? It's an interesting approach. What it is, and I'm just going to give you a little bit of a background about what it is, and you can share a little bit of our approaches so you can see how this works. But if you want to get somebody to do something that you know is good for them, that they're not likely going to be all that motivated to do, this is one way to approach it. So it is this idea of trying to get people to do this, right? To get them even motivated to be motivated is pretty much where we're coming from with motivational interviewing. But it really is, we have this temptation in healthcare is to, we know what's good for patients, so we just tell them, here's what you need to do, this is what will be good for you, go do it. And that doesn't work. It really doesn't work. So this motivational interviewing approach is something that we're trying now to see if it'll make a difference. It itself is not an intervention. It's what you do to prepare somebody to engage in the intervention that you want them to do, whether it be exercise or for us to follow a low sodium diet. So people sometimes call this an intervention, but it's not. It's something that prepares them to engage in the intervention. So this really does something different from what our typical approach is, which is to tell people what to do and say, here's what you do, here's how you do it, here's when you do it, go do it. And if they don't come back and they're not doing it, then we get mad at them and say, well, I'm not going to treat you. If you're not going to do what I'm going to tell you to do, then I don't want to treat you. And that's just been where we are. So it is this idea of what we call dancing with the person rather than wrestling with them. So we're wrestling and saying, I'm going to make you do what I want you to do. And that's not working. So what we're going to do is say, let's work on this together. So it's more a dance than a wrestling match. And this is really where this kind of comes from. People are generally better persuaded by the reasons in which they themselves have discovered than by those that come into their minds of others. So it's the idea that we always go to them and we say, this isn't a good idea for you, you need to do this. So the trick here is actually to go back step and actually get these, it's kind of like being a salesman. It's getting them to really say, you know what, this is what I need to do in order to get better. To help them discover that rather than tell them. So really what you're ending up doing is you're not going to tell them what to do. You're going to get them to tell you what they think they should be doing. So this is the difference between education and motivating. And this is probably kind of where we shift our thinking. So educating is effective for people who perceive a need to know or want to change. So you have somebody who's coming in saying, I really want to start an exercise program, what do I need to do? Perfect, then education works for them. But if you have the people coming in and saying, I suppose maybe I should exercise, but I have no desire to do it, I don't even care, I don't want to do it. So this motivating is effective for people who do not see the problem or don't wish to change. So So this is really where we're coming from. And when we think about things like sodium diets or exercise, this is probably one of the things we need to sort of do. So this is the general strategy, but you'll notice what happens here at the very end is, so we spend a fair amount of time, when we go to do these interventions, right now we're doing them in the patient's homes, but we spend over, and before we even get to talking about the idea of doing a low sodium diet or having them engage in that, we spend at least an hour or more talking to them, getting them to actually work their way through this before we even talk to them about whether or not they should follow a low sodium diet. So it's this idea, what you do is you establish a rapport, we set an agenda, and probably when you talk about the agendas, you sit there and you say, okay, we're going to talk about this, and for us, we go in and we say, we're just going to talk a little bit about your heart failure, you're going to tell me, I'm going to ask you some questions, you're going to tell me about where it is, how it's affecting your life, what you think it is, how things have changed because of heart failure, and all those other things, to kind of get them an idea, for them to set that up. And we do things like then, when we get that, we set this agenda and they have some idea of what they think. If you get them to the point of saying, okay, well, maybe I need to do something about this, or if I do something about this, it will help me get better, or decrease my symptoms, then you can start to broach the idea and say, okay, well, here's one of those things that will help. If you do this, this is what will happen. And then what you do is you get them to say, okay, I understand if then maybe what I should do is follow a low sodium diet. Then it's like, okay, we're going to do this thing about how important do you think it would be for you to do this, and how confident do you think you are in doing it. But then you do this stuff about exploring all that and building it. But then it's way at the very, very end before you finally just say, here's what we should be doing. You actually have the patient say, here's what I should do. So it's getting them to do that rather than we do. So we don't tell them, we get them to tell us. So it's based somewhat on this whole, you've heard about the stages of change, pre-contemplation, contemplation. Well, what happened with this is we've done all this before, and tried to do different interventions depending on where we thought the person was in their stage of change, and it hasn't really panned out to be as wonderful as it looked in theory. So what they did here is they just assumed everybody, you just come in with the assumption that nobody's ready to make the change and just work from there. For some people that are somewhat ready to make the change, you might have to spend less time getting in there. For those other people who do not, but you approach everybody from that same perspective. So we would just go in at some point, and I don't know that we would start with diet because we would talk more about, tell me something about your heart failure. You get them to tell us and explain everything to them, and we sort of slowly, gently move them in the direction you want them to go. But you would do this, you might want to talk about their level of activity. Tell me what you're doing now, and how's that working for you, kind of thing. But you assume that nobody's ready. You spend a lot of time doing that. What you try to do then is really develop this dissonance between what they, this whole thing where they finally get to see this conflict. Here's what I want to do. I want to become more active. I want to play with my grandchildren. I want to be around to see one of them graduate. So they want to do it. And then you say, well, what are you doing to make sure that happens? What are you doing to help make sure that you're there to play with your grandchildren? What are you doing to see that you're more active? To get that dissonance, to say, here's what I want to do, here's what I'm doing. So you get that conflict in them to say, okay, well, maybe I need to do something. If this is what I want to do, this is what I'm doing. Maybe I need to do something to be able to get here. So it's to try to get them to realize, hey, there's a disconnect between what I would like to see in my life and what I'm doing now as well. So it's just uses a lot of probing questions about telling them, why do you think this is a problem? Or, so it sounds like now you're thinking here you're really unhappy, but things can't stay the way they are, that something needs to change. You want to get them to that point of saying that. So again, people are more convinced about arguments that they thought about themselves than the ones that we present to them. So it's that whole idea of what makes you think it's a problem, instead of saying this is a problem, you need to fix it. That whole idea. Or it sounds like things can't stay the way they are, what will you do about it? It's that whole idea of doing that. At some point when you get them to say, okay, I need to do this, I need to do something, and here's what I need to do, you kind of can get them to actually do this and say, how important is this to you? And if they make it a lower important, somewhat important or whatever, you want to see if you can't get them to sort of get over here to the higher importance. You can ask them additional probing questions to really get them to think about, well, wait a minute, this really would be important. If I really want to do this, or this is my goal, this is where I want to go, you can do this as well. And then you also want to know the confidence, because if they have really low confidence, so they think it's really important to do, but they have no confidence that they can do it, then you know where to target. You know, okay, I already know they think it's important. What I have to do here is help them figure out how they can do it as well. And then it's all negotiated. This is all negotiated. We don't tell them what to do. We sort of, they want to know. You just kind of negotiate with them. If you want to do this, well, here's what you can do. If you did this, and it could be a sodium. It's like one of those things you try to negotiate. Say, okay, if you really like, you know, some specific food. Well, if you really like that specific food, well, if you do something like restrict other sodium during the day, you might be able to have this. So it's the idea of helping them negotiate what they need to do to sort of get their priorities but still meet their goals. So it's always negotiated with the point. Again, it's a dance. We don't tell them what to do. We ask them what to do, and then we actually, you write out a plan and you say, tell us what you need to help you meet this plan. So it's pretty much negotiated, and it's all patient-driven. It's not driven by us, it's driven by the person. And that's a really hard thing to do, because my temptation is always to just say, well, here's what you really need to do, here's how to do it, but to step back and be really cautious and slow and help them work their way through to come up with this solution. It takes time, but it's worth it in the end. Some of the things that are really there is to prematurely focus on the change, which is really easy to do, because you go in there with an agenda, you know what you want to do. You want to get this patient to do this activity that you think is important for them to do. So it's really hard to really not sort of want to get there as quickly as possible. So it's to be patient and go there as well, to push ahead too soon, and to really simplify solutions, because really sometimes a lot of things we want to do probably have complexity. You're going to get somebody to engage in exercise, just telling them to do it, or give them a real simple solution like, oh yeah, all you have to do is go walk around the block a couple times a day. You know, you're going to figure out whether or not there's problems with that, and to give advice, which is really easy to do because you know what's there, what advice is there. But to avoid doing those things, it's not as easy as it sounds to do either. And I think the other thing to do is this is really good, is never miss a good chance to just shut up. So this is really a time to listen rather than talk. And it's really, sometimes it's against, at least sometimes my nature, to just, because I'm going to tell them what to do versus listening to them as well. So those are really some of the approaches to this. This is, I've given you a really simplified overview of this because it really is a very, it's a talent, it's an art, and it's a skill to develop. There are books and manuals to do this. We underwent a training session, like a several-day training session to do this, and we actually have somebody in our College of Nursing. So when we go out and do these interventions, the nurses that are doing these interventions, we actually audio tape, record the intervention and have those scored to see how closely our people doing the intervention are following the skill set or the types of things that you're supposed to do with motivational interviews, that we state, that we actually follow what's supposed to be done in there as well. But here's the resource, and there's a website for that as well. I'm happy to send people these slides if you want. And then I'll just have to finish with this, because this is my perspective. And I suppose it can happen with activity as well, or exercise. It can be your medicine as well. Okay, let's. How's a whirlwind tour? Any questions? Yeah.
Can I ask you an obesity question?
Yes.
So heart failure is kind of finding a common pathway of a lot of different things.
Yes.
And when they were looking at the study, that obesity seemed to be protective. Did they take into consideration why the person had heart failure, the actual mechanism of the failure? So that if, you look at, there's a U-shaped curve with just overall mortality, and people that are underweight tend to, die sooner than people that are normal weight, and it starts going back up to a certain point. And I just wonder if there are other things that led to the heart failure, like sarcoidosis, or just go down a list of things that can cause heart failure in people that might be underweight or normal weight that are more severe than the things that cause it in obesity.
So there's been a lot of struggle to try and explain the whole phenomenon, and I'm glad you put up the you brought up the shaped curves, because when they plot these people with obesity, you do get a sort of that curve. Underweight people have a real high mortality rate, and as BMI goes up, it goes down, it goes down, it goes down until you reach about a BMI of over 40. So the morbidly obese, then it starts going back up. So there's a sweet spot in there. BMI's between 30 and probably 40 or maybe 45, where that might work. But morbid obesity, again, those people they have a high mortality rate as well. So that part is in there. So it's just this little sweet spot in there. And a lot of questions about why this happens. One of them is that people who are obese, because they're more symptomatic and short of air to begin with, might actually be diagnosed earlier. So we're following them for, they're already diagnosed with heart failure, so we're following them for a longer time. So they're going to look like they're surviving longer just because we diagnosed them earlier. People with heart failure, it can be a while before you diagnose them because it's symptoms that drive them to the hospital or the physician to be diagnosed. And if you know, over time, if these symptoms are slowly going on, and we already talked about the fact that if they start to become symptomatic, they just become less active, so they're less symptomatic. So it takes a while before they get so symptomatic or somebody else notices that, gosh, you can't even walk to the kitchen without getting short of breath, you need to go see your doctor. Then they get diagnosed. So lots of times normal weight people are getting diagnosed later, so they probably have a shorter survival just because of the time of diagnosis. So that was one theory. Other theories are that it's really, those people who are obese actually tolerate the drugs that we put them on better than normal weight people, the ACE inhibitors and some of those other ones. They're just because of their physiology. There's that. And again, a lot of the etiology for obesity is going to be some kind of cardiomyopathy versus like a lot of those people develop just because they're big. It's like hypertension, you develop cardiomyopathy just because the heart's been working so hard to do all that. So rather than ischemic heart disease, which happens in some people that are normal weight, so their heart they have less. It's ischemic, so they have less muscle to pump in. So that might be part of it. One of the other people, Stephan Anker, who is a very big guy who now knows obesity not being a big problem, has said, obesity itself is exercise. Because if you're big and you're pushing all that weight around, so just for a person who's overweight or obese to get up and walk around is probably doing more exercise than a normal weight person under that same stat. So he's just saying, just being obese is exercise. So that might actually be beneficial as well. So they actually might be engaging in more exercise just by having to get up and walk around. So that was one of his arguments. So there are a bunch of them out there. I think a lot of clinicians want to find reasons to dismiss it because they don't want to change their thinking. They've all said lose weight. That's what we do. But yeah.
As a follow-up on that, did they also look at people that started out obese and that recommended you lose weight to see if they actually have better life expectancy than people that stayed obese?
There has been no trial of where they've actually put people on a weight-reducing diet. There's been some, just naturally, the people that do lose weight, if they're just losing weight spontaneously, those people don't do very well. And it might just be because they're losing weight in response to their heart failure becoming more advanced. And so that's why, as it is, people develop cachexia from all chronic conditions. But nobody's done a controlled trial of weight loss in patients. Now, a lot of people where they do the hyperbaric or where they do the bypasses, gastric bypasses in those patients. But I think you're dealing with a whole different issue there. Some of those people have done better. A lot of those were really morbid obese to begin with, so they probably would do better. Those are the people that were really resistant to that, the ones that are doing those surgeries in patients with heart failure to drop weight. They're the ones that obviously, because it's a threat to their practice, but they're the ones that are the most resistant.
I like that you brought up the whole part about obesity being exercise.
Yeah.
Because we find in other aspects of fitness, muscular strength and endurance, maybe not as much endurance, but certainly muscular strength. The obese children we work with are incredibly strong. They may have orthopedic issues in terms of load issues, but in terms of bone density, you don't see the osteoporosis, you don't see other aspects of fitness. So I like that you brought that up as well. Maybe not with this group, we have to worry so much about classifying people as obese with BMI, but with younger folks, body composition gives us a better idea. I just tested a group that's getting ready to train for a bodybuilding competition in October, and out of the 8 people, 4 people were considered obese by BMI, but they were males, and their percent fat was under 7% by DEXA, and And they kind of laugh, and I always say, well, good thing your insurance rates aren't based on your BMI. So maybe it isn't as much of a problem in this population.
Well, with patients with heart failure, because they're not exercising.
Yeah.
So it's pretty much all looked at. I just want to say this briefly because I know we're running out of time. We looked at our survival outcome in our patients with high BMIs, and we find that it's the people who are obese, and we did a lot of these were just mortality. We did all-cause hospitalization, all-cause mortality, because you got to think about the contribution of obesity to comorbidities as well as heart failure itself. So when we did that, it's the people who are obese with diabetes have equally poor outcomes. It's only the people who are obese who don't have diabetes as a comorbidity that have the better outcomes when you look at all-cause hospitalization and combined with all-cause mortality. So you have to, so it's not a blanket thing. I think you got to consider those comorbidities in some of these people as well. But I think recommendations to lose weight. In fact, a lot of the guidelines now have dropped weight loss as a recommendation, unless there's truly, obstructive sleep apnea or some other life-threatening condition with obesity. It's interesting, it's gone away. So,
What's
okay.
the sodium content of your tomato and V8 product?
We're using the low sodium, so that's in there. So I think it's it's like 100 milligrams or something. So it's fairly low. I think it's around 100 milligrams. So it takes some getting used to, but I don't get it.
Well, thank you very
All right,
much.
well, thank you all.